Schedule II controlled substances have a high potential for abuse, severe psychological or physical dependence risk, accepted medical use in the U.S. under strict controls. Pharmacy techs should know that Schedule II prescriptions cannot be refilled and generally require a written or electronic prescription. No refills allowed.
Opioid.
These are powerful pain medications with high abuse and dependence potential. Morphine is a classic, strong opioid analgesic. Morphine is the gold standard for severe pain. It works by strongly activating mu-opioid receptors in the brain and spinal cord. In the liver, morphine is converted into an active metabolite called M6G, which can build up in patients with kidney problems. That buildup increases the risk of sedation and respiratory depression. Morphine also releases histamine, which is why patients may feel itchy, flushed, or lightheaded. Naloxone is used to reverse morphine overdose. Morphine is named after Morpheus, the Greek god of dreams. It has been used medically since the early 1800s. Oxycodone is commonly prescribed for severe pain. Oxycodone is a semi-synthetic opioid used for moderate to severe pain. It primarily activates mu-opioid receptors. It is metabolized by CYP3A4 and CYP2D6, meaning many drugs can raise or lower its levels. Extended-release tablets must never be crushed because doing so can cause a fatal overdose. Oxycodone has high oral bioavailability, which contributes to its abuse potential. Oxycodone was one of the main drugs involved in the modern opioid crisis. Extended-release oxycodone was originally marketed as being low risk for addiction. Hydromorphone is a Schedule II opioid also known by the brand name Dilaudid. It is about 5 to 7 times stronger than morphine. It causes minimal histamine release, making it useful for patients who can't tolerate morphine. Hydromorphone is metabolized in the liver to inactive metabolites. Because it is so potent, even small dosing errors can be dangerous. The name Dilaudid comes from a chemical description, not marketing flair. A dose measured in milligrams can be the difference between pain relief and overdose. Methadone is a Schedule II synthetic opioid used for pain and opioid use disorder. It activates mu-opioid receptors and blocks NMDA receptors. Methadone has an extremely long and unpredictable half-life. This means it can build up in the body and cause delayed respiratory depression. It also prolongs the QT interval, increasing the risk of dangerous heart rhythms. Methadone was developed during World War II. It can last so long in the body that patients overdose days after a dose increase. Meperidine, also called Demerol, is a Schedule II opioid that is rarely used today. Its metabolite, normeperidine, is neurotoxic and can cause seizures. The risk is especially high in elderly patients and those with kidney disease. Meperidine can also trigger serotonin syndrome when combined with certain antidepressants. Meperidine was once popular for labor pain. Today, many hospitals avoid it entirely. Fentanyl is a Schedule II synthetic opioid that is about 100 times stronger than morphine. It strongly activates mu-opioid receptors. It comes in IV, nasal, buccal, and transdermal patch forms. Heat can dramatically increase absorption from patches, leading to overdose. Illicit fentanyl is a major contributor to opioid-related deaths. Fentanyl doses are measured in micrograms, not milligrams. A few grains can be lethal. Hydrocodone is a Schedule II semi-synthetic opioid. It is commonly combined with acetaminophen in products like Norco and Vicodin. Hydrocodone is metabolized into hydromorphone. Excess acetaminophen increases the risk of severe liver damage. Hydrocodone has a high potential for misuse and dependence. Hydrocodone used to be Schedule III until 2014. It was once one of the most prescribed drugs in the United States. Codeine is a natural opioid that acts as a prodrug. It must be converted into morphine by the enzyme CYP2D6 to work. Some people convert it too quickly, which can cause overdose. Codeine is used for mild pain and cough suppression. It is not recommended for children after tonsil surgery. Codeine is the drug behind lean. For many people, it barely works at all. There is one more drug we haven't mentioned that is a traditional narcotic source, but still considered a Schedule II drug. Opium is a Schedule II substance derived from the poppy plant. It naturally contains morphine, codeine, and thebaine. Opium activates mu-opioid receptors and has extremely high addiction potential. Today, it has very limited medical use. Opium has been used for pain relief for thousands of years. Every modern opioid traces back to this plant.
Stimulants.
These drugs are used medically for ADHD and narcolepsy, but with high abuse potential. Amphetamine is a Schedule II central nervous system stimulant. It increases the release of dopamine and norepinephrine in the brain. This leads to increased alertness, focus, and energy. Amphetamine is used to treat ADHD and narcolepsy. Common side effects include insomnia, decreased appetite, and increased heart rate. High doses can cause anxiety, paranoia, and psychosis. Amphetamine was once sold over the counter in the 1930s. It was marketed as a treatment for almost everything. Amphetamine and dextroamphetamine is a Schedule II stimulant combination. It is best known by the brand name Adderall. Dextroamphetamine is the more active form affecting the brain. This combination increases dopamine and norepinephrine signaling. It improves attention, impulse control, and wakefulness. Misuse can lead to dependence and cardiovascular problems. Adderall started as a treatment for weight loss, not ADHD. It is one of the most recognized prescription stimulants in the world. Methamphetamine is a Schedule II stimulant with very limited medical use. It powerfully increases dopamine release in the brain. It also blocks dopamine reuptake, causing long-lasting stimulation. Medical methamphetamine is sold as Desoxin. Chronic use damages dopamine neurons and causes severe addiction. Illicit meth is associated with extreme neurotoxicity. Yes, methamphetamine is technically prescribed. No, most people are shocked to learn that. Methylphenidate is a Schedule II stimulant. It is commonly known as Ritalin or Concerta. Unlike amphetamines, it mainly blocks dopamine and norepinephrine reuptake. It is used to treat ADHD and narcolepsy. Extended-release forms provide smoother symptom control. Side effects include appetite loss and insomnia. Methylphenidate works more like cocaine, but much slower and safer. That comparison shows up on exams a lot. Laced X-amphetamine is a Schedule II stimulant. It is best known by the brand name Vyvanse. It is a prodrug that must be converted into dextroamphetamine in the body. This conversion lowers abuse potential compared to other stimulants. It is used for ADHD and binge eating disorder. Crushing or snorting does not make it work faster. Vyvanse has a built-in time delay. Your liver has to turn it on first.
Other substances.
These are less common, but still in Schedule II. Alfentanil is a Schedule II synthetic opioid. It is a very fast-acting mu-opioid receptor agonist. Alfentanil is primarily used during anesthesia for short procedures. It has a rapid onset and a very short duration of action. This allows anesthesiologists to control pain precisely during surgery. Respiratory depression is the most serious risk. Alfentanil works so fast that it is often gone before patients fully wake up. It is basically the blink and you miss it opioid. Amobarbital is a Schedule II barbiturate. It enhances GABA activity in the brain. This causes sedation, hypnosis, and decreased anxiety. Amobarbital was once used for insomnia and anxiety. It can cause respiratory depression, especially when combined with alcohol. Barbiturates have largely been replaced by benzodiazepines. Amobarbital was nicknamed Truth Serum. It was used in old interrogations and psychiatric interviews. Pentobarbital is a Schedule II barbiturate. It strongly enhances GABA-mediated inhibition in the central nervous system. It causes deep sedation and hypnosis. Pentobarbital is used for severe seizures, sedation, and veterinary euthanasia. Overdose can cause coma, respiratory failure, and death. It has a very narrow therapeutic window. Pentobarbital is more commonly used in animals than humans today. The line between sedation and danger is extremely thin. Many combination products with high-potency controlled ingredients also fall here, e.g. guaifenesin, hydrocodone blends. Schedule II drugs are dangerous but still have medical uses, unlike Schedule I. They include narcotic painkillers, powerful stimulants, and some less common barbiturates, and are among the most regulated prescriptions you'll see in a pharmacy.